Welcome all to the listeners of OrthoTV, and I think we've been doing this for the last 1 year, the Master Shoulder series, and we're having a lot of master speakers across. And today we have none other than Dr. Professor Philippe Landreau. I think this name needs no introduction across the globe, and especially in the Indian and the Middle East soils. I also have a slight privilege to have him as my colleague in the Middle East, my senior colleague and things there. But to have a just short talk, he's an expert shoulder and knee surgeon, and his works knows no bounds. He's been attending different sports needs, sports injuries, and his global works in terms of research, publication. I think I don't have a count of how many names he has on the papers, and it's lovely to see him on his hands play magic on the live surgeries and stuff. So if you let me to talk about him, I would take this entire 1 hour to talk about him. So I wouldn't love to see. And I also have I would also thank my colleague Dr. Senthilvelan from MIOT Hospital, Chennai, for sharing his valuable time to moderate this session. So the entire concept of this session is not to have too much talks, to listen to the master's way of doing things, and at the end we have the Q&A. I just asked Dr. Senthil to have a couple of words, and then we pass on the stadium to Dr. Philippe.
Thank you very much, Dr. Karthik. Sorry about the delay. We know we've heard so much, and we've actually listened to Dr. Philippe in number of conferences, and we are very eager to actually, let him speak on the, Latarjet. He has had so much innovations, and his technical tips will definitely help in all the younger individuals to actually, take on Latarjet and how to actually reliably do it without any mistakes. That's what we are all waiting to hear. So without much ado, we'll go straight to the talk, sir. Thank you.
So I would like to give it to the man of the show, the man of the match, our boss.
Thank you, guys. And thank you, Dr. Raj. Thank you, Dr. Senthil. It's a pleasure. Really appreciate your invitation, and particularly coming from you, young, brilliant orthopedic surgeon. So this is good, and it's always a pleasure to share with you guys. And I understand with your introduction that the topic is and the objective is to be very practical for a particularly young surgeon or people who are not familiar with the Latarjet. And you said that you listened to me several times. I hope it will not be boring to listen to me one more time. But
no, definitely not.
So I will share my presentation already. And so the plan, you asked me to talk about the Latarjet, the open Latarjet. We say mini open, but whatever, because anyway it's open. If you can try to do mini open after some time, it's okay, but don't push too much to do mini open if it is the beginning of your experience, because you must be comfortable with that. And I think it's important to talk about the open Latarjet because we know that it's a very trendy and amazing way how arthroscopic Latarjet can be demonstrated. Having said that, the majority of people are not doing so much Latarjet per year. So for that reason, I think you should be more comfortable. You should be first comfortable with open Latarjet, and then you can translate and move to arthroscopic Latarjet if you want, because in the literature, there is no big difference in between if we talk about experimented surgeon. Latarjet, anyway, as an introduction, I would say that, and I don't have to convince you because the literature now fortunately support that. It's an amazing and fantastic surgery for the treatment of anterior shoulder instability, particularly in case of bone deficiency, of course. And it's a very French surgery because Latarjet was a French surgeon, and I've been educated, like all my colleagues, shoulder surgeon, French surgeon, with Latarjet. And for us, it's a sort of thing that we learn from our residency. And when we see the literature, the percentage of complication that have been reported in some series until 30%, there is a paper showing 30%. It's really scaring. I mean, who will do a surgery if you look at there is a 30% risk of complication? First of all, you need to read cautiously what means complication, because they include the recurrence in this kind of thing, some scar problem. But in general, we can say that some series report important percentage of complication that we don't know. Honestly, we don't know when we are used to do this kind of surgery. So probably the main reason, because we are not better surgeon than all the other guys, we French, but we have more experience. And I think the problem is that it's a technical demanding surgery, probably not well explained, probably. And for that reason, if you want to decrease the percentage of complication, because honestly, in our experience and in my experience, this surgery has a very, very low rate of recurrence and very low rate of complication if you follow the recommendation that our master and our mentors told us, like Gilles Valch and other people like this. If you listen to with these guys, and if you go to all the details, this is a very safe surgery. So this is why I wanted to talk about tips and tricks to make it perfect. So it means, you know, when you learn surgery, surgical procedure, actually it's only an accumulation of different tips and tricks from the beginning and the end, and then you take what you want, but at least you build your own surgical technique to do in the better way. These are my disclosure. I would say the first tips and tricks, we tried 10, but we are more. But the first one is understand the concept of Latarjet. If you don't understand the concept of Latarjet, which is sometimes forgotten, maybe you can do some mistake. There is a triple blocking effect on the Latarjet. And I put by purpose the sling effect as the first one. I know that there are some controversy about that, particularly where people were using a bone block and they pretend to have the same rate of success than Latarjet. Probably, but be careful, because remember the experience of Bankart arthroscopic surgery. It was very enthusiastic. A lot of people said that arthroscopic Bankart was fantastic for the treatment of anterior shoulder instability with a low rate of recurrence. And a few years after, we started to have some data, particularly the very famous paper from Burkhardt and Joe De Beer, showing that if you treat the Bankart, if you use the Bankart for the bone deficiency, you will have a high rate of recurrence. So it means, in other words, we went to some series showing 5% of recurrence, and suddenly, when the follow-up was bigger and less loss of follow-up, we realized that it was not the case, and we had to adapt and to do a tailored treatment for this kind of thing. So to come back to Latarjet, there is three effects: sling effect, bone effect, and Bankart effect. And this sling effect is important because it's literally a plasty. It's not only a repair. So not only you have the bone effect, which is important, but probably not so important, because, you know, the coracoid process is not very thick. And if there is a big glenoid defect, you have to use ISAKOS, Edenebinet. But the sling effect is extremely important. And I like to show that it's one of my case. And I did by purpose this video just before to close the capsule. If you close the capsule, you see on the right, just behind the retractor, you see the coracoid process fixed already with the screw. You don't see the screw, but it's behind the retractor. And you see the subscapularis, it's the right shoulder, separated, you know, split. And you see the sling effect with the coracobiceps and the inferior part of the subscapularis muscle and tendon. So obviously, this effect play a big role to stop the humeral head to go anteriorly. And I encourage you, when you do a Latarjet, to stop and to do that before you close, and just to convince you that it's a good surgery. What are my indications based on that? When it's only a Bankart, I do a Bankart. When it's a Bankart plus ISAK, usually I do Bankart en remplissage. when there is a glenoid bone loss, it's a perfect scenario for the Latarjet. And when the glenoid bone loss is combined with a very important heel sacs, this is where there are some controversy. It happens sometimes that I do Latarjet and remplissage if I feel that the heel sacs is big, and because probably some failure of Latarjet. Remember, you want the series in the good series 2 or 3% of recurrence only, but probably this recurrence are due to if we exclude, of course, any mistake, surgical mistake. If the bone graft is correctly positioned, probably it's linked to importance of heel sacs. And it's a table showing my global indication, but actually more the patient has a hyperlaxity, more the patient is practicing a contact or collision sport, and more it's a young age, because you know that the risk of recurrence is important, more I will go for a Latarjet. So it happens sometimes that I do a Latarjet if there is even if there is a glenoid bone loss which is subcritical, because the patient could be hyperlax. I'm not talking about multidirectional instability, I'm talking about hyperlaxity, or if he is playing a collision sport, particularly if he has a young age. So it's not the easy score. Okay, easy score is important, but this is just to summarize the way I manage my anterior shoulder instability. But actually, it's a bit like the easy score, because you find all the same criteria. Number two, after understanding perfectly what is the concept of Latarjet, get the appropriate instrument. It's not an easy surgery if you don't have the good instrument. So don't go like this without preparation. I like to show this picture which summarizes all my instruments. You see in the black rectangle, you can see the retractor. The majority are a usual retractor like the Oman, but you have this Bankart retractor that you can use Gelpi if you don't have a Bankart retractor, but it's orthostatic, is very helpful. The Fukuda retractor on the right side of the Oman retractor is very helpful to retract the humeral head. The simple Steinman rod that you can find in any orthopedic surgery theater is important to retract the superior part of the subscapulate. The right angle, the angulated 90-degree saw is very helpful. You can do without, but in this case, you have to open more. If you want to do a mini-invasive with a 90-degree saw, you will see that it's easier to manage the Coracoid process harvesting, and use this kind of Alice or Muse grasper, which are a grasper with 4 teeth, because if you use a cochlear to grasp and to take your Coracoid process, it will turn. You will not control the rotation or the flipping, and for that reason, you need 4 teeth to really control properly. And the rest of the instruments are quite standard. So even some companies, they provide some clever instrument to automatize and to be more accurate when you do your Coracoid preparation and drilling, but you can do without. Number 3, you need to get a good assistant. My dream is to have this kind of assistant with I don't know, 9, 10 arms, and you know, she or he can do everything. Actually, what does it mean? It means you need to have the good retractor. So you need to have a good assistant used to retract, and not a passive assistant. Actually, if you have good retractor, more you have the retractors, less you need assistant. And usually I do it with only one assistant plus the nurse for the instrumentation. And if you have the good retractor that I will show you on the flow of the surgery, you can manage with a small team. But it's important to understand that these surgeries, some of my colleagues, I remember in the past, said the good Latarjet, it's a question of retraction. And it's true, because you want to do something, you don't want to do a big incision, particularly now we do arthroscopic surgery, so you know you don't want to do a 10 centimeter incision. So you can do that at the beginning if you are not experimented, but at the end you should do a small incision. Position of your patient is important, like any surgery. Gilles Valch talked about that you can do in a normal shoulder, normal table. You don't have to do a beach chair or this kind of thing. You have to put a holder under the elbow, but don't put the holder too low towards the feet of the patient, because you need to be in front of the patient, and if your holder will be against you. So put the holder in that way, and put the sandbag at the it's not always mandatory, but it depends the shape and the anatomy of the patient. But if you see that the deltopectoral, I would say, area is not enough open, when you put this patient on the dorsal decubitus, put a sandbag on the medial border of the scapula just to tilt a little bit the scapula and to avoid to close the deltopectoral area, which is important if you want, like any deltopectoral approach. Number 5, make a good coracoid harvest. Don't fragilize, don't do too small, and don't spend too much time. It's important to go straight forward. So on the coracoacromial side, you have to leave a few millimeters if you want to reattach the capsule on there. For the pectoris minor, you can cut the pectoris minor very close to the bone, and of course, you keep the conjoint tendon, which would be the sling effect. This is the Bankart orthostatic retractor. You see the incision doesn't need to be very important. So you use an army retractor up. So your assistant do that, and the other one or the same aspirate. And then you have to clean the superior part of the coracoid process until the attachment of the coracoclavicular ligament that you don't want to manage. On the lateral side, it's the right shoulder. On the lateral side, you open you cut the coracoacromial ligament, and you continue by releasing the lateral border of the coracobicep. It's not easy to do a video of Latarjet because the incision is very small. Then you have to do the coracoid osteotomy. This is where the 90-degree saw is interesting, because if you have a straight saw, then you have to open more superiorly to be perpendicular to the coracoid. So you have to harvest the distal part, the half distal part of the coracoid. So you should harvest, it's not really indicated on this drawing, but you should harvest until the first insertion of the trapezoid and conoid, particularly trapezoid. This is a good landmark. So when you do that, remember that you have to move the arm as well. So this is why I don't want to put on the system to hold the hand, because you need to have the hand free. Because when you do that, you have to do adduction. When you go on the side, you have to do abduction. So when you move the upper limb, you can facilitate and move the window of your like this. So replace the army retractor by a bone lever retractor, which is usually called the Batman with the 2 ears, more stable than the Oman. And then you use this 90-degree. Actually, this one is quite long. You can use a smaller one, shorter one. And you go from medial to lateral, of course, because you don't want to go from a lateral to a medial with the brachial plexus, which is not too far, because you know the concept. If in arthroscopy, we don't recommend to go medial to the coracoid process, when you do surgery, you have to respect the same rule. So this 90-degree saw is very helpful. And when you do that, the arm should be close to the thorax because it opens more medially. If you are in abduction external rotation, your window move laterally. So, you will see when you try, you will adapt the position of your arm to facilitate the approach. Then you use this kind of Fortis grasper that allow you to turn and to manipulate the coracoid process in the best way. Then you clean the fat tissue which is under the coracoid. You know what it is. But when you do a coracoclavicular fixation for AC joint dislocation, arthroscopically you have to clean the inferior part of the coracoid process, which is the same thing. Then release the conjoint tendon, but always think about the musculocutaneous nerve medially. Don't go more than 2 centimeters. It does depend on the size of the patient, of course, but don't go more because there is a risk for the musculocutaneous nerve. And don't do a strong traction of your conjoint tendon because you can make a lesion by traction of the nerve. So be careful with that and retract your coracoid more medially than laterally when you protect for further step of the surgery. Number 6, make a good coracoid preparation. This is absolutely crucial. And I believe that some failure can be due to the fact that people don't prepare correctly the inferior part of the coracoid process, particularly to remove this cortex. So you finish the preparation and the cleaning of the inferior part, decorticate the inferior surface, coracoid process sometimes is very thin. So this is why I don't like the technique, which is the curve technique developed by Debye, you know, the arc technique, which is to put the coracoid process straight, because you have a high risk of fracture. Use the traditional one, this one, but this is my advice. Then you can use only one screw. I use only one screw. I'm known for that, and I have some data to show that it gives the same result and less risk of fracture. This, particularly if you have a small coracoid process, but you can put two screws if you prefer, as long as you don't fragilize. So when you do 1 or 2 screws, you measure the distance, or either you do this kind of thing with a specific ancillary, or you can use this small, my technique, I've been using that for years. You use a ruler, you measure the lateral, from the lateral part to hole, which is usually 7 millimeter, and you measure from the hole or the last hole until the inferior part of the coracoid process, and you keep that, mark that on the table with a mark pen. Marking pen, you put gauze inferior with the army retractor. It retract and medially it retract the coracoid process, and then you can approach number 7 the subscapularis by splitting the subscapularis and open the capsule horizontally. I don't recommend to do vertically the capsulotomy, but horizontally. I will let you know why. And you can split classically between 2/3 proximal and 1/3 distal, or you can do half-half. If you do half-half, you will have more sling effect with the inferior part, because you will have more subscapularis tendon and muscle to do the sling effect with the coracoid process. So then open horizontally the subscapularis, and then the capsule. You put you can do this kind of dissection with medially with gauze or any instrument like scissors, and then when you put the gauze between the capsule and the subscapularis, and then you cut the capsule until the bone, and you replace the army retractor with Oman. You see that I put Fukuda retractor at this stage laterally to retract the humeral head. Is very convenient. And on the right side, on the medial side, right side on your screen, I put this not Oman, because I prefer to use a Batman, which is larger and more stable, to retract the subscapularis. And you see that you start to have a good approach of the anterior part of the glenoid, the neck. So 7, you have to, after this approach, you have to prepare the bed for the coracoid. Again, probably one of the mistakes of people when they are not used to do that, they almost don't decorticate. You know that the Bristow technique is without decortication of the bone. And this is why I don't confuse and compare Bristow and Latarjet. This is not the same technique, and I'm surprised sometimes people call Bristow Latarjet, which is a nonsense for someone. I'm not telling that Bristow is less good or not. I don't think it's equivalent, but it's another surgery. But if you want to do a Latarjet, don't call that a Bristow Latarjet. Latarjet, you want to debride and to get healing of the bone, so bone consolidation. This is a concept. You see here, if you don't use this Steinman rod to retract the subscapularis, particularly when the patient is quite muscular, you will struggle a bit. So you have to use this Steinman that you slide under the subscapularis. Hip surgeon, they know that how to use this kind of thing to retract the muscle. And then you can have a very good access to the anterior part of the glenoid. You need only access to the 2/3 distal of the glenoid, because you will not put your graft on the top part of the glenoid, of course. And usually, when you prepare properly with the curved osteotome, here, to summarize again, you have the right shoulder, you have the Fukuda retractor laterally. Medially, you have the Batman retractor with or without a sponge underneath to increase the effect of retraction. You have the Steinman rod superiorly, and you have the Oman retractor that you must keep close to the bone, of course, to avoid any axillary nerve damage. Then when you finish your preparation, usually you should get a sort of a triangle of quite debrided and cancellous bone. Don't remove too much, but remove enough to make it bleeding. This is absolutely crucial. Then number 9, you have to drill exactly on the correct place to get a good compression and to not overhang. This is one of the main problem of Latarjet. If you overhang, so in other words, if you put your coracoid process too laterally, so it means lateral to the cartilage of the glenoid, and there is data for that. Now we know that it increases the risk of osteoarthritis and pain in short term and osteoarthritis in the long term. So be careful. Either you use some offset or some guide proposed by the company for that. Otherwise, if you don't have, you can use the simple guide for poor surgeon that I like to use every day. You take a ruler, you cut the ruler, you measure what you had on the coracoid, and you produce the measure simply like that on the glenoid neck. So, you use this kind of thing. I measure 7 millimeter and 10, so 7 millimeter from the border of the glenoid. I put a mark here, and then I measured from down to top to as 10 millimeter, and I like to do that, to cover. Usually, you like to cover between 2 and 5, or 3 and 6, but 2 and 5 usually the recommendation. Then you drill. When you drill, try to be parallel to the glenoid surface. You will never be parallel. If you look at your CT scan control, it's never parallel, but try to be the maximum parallel and don't go too far because you don't want to damage the suprascapular nerve, which is the end of the suprascapular nerve behind. And usually it can bleed a little bit, but just when you do that, we said in the front, I remember when I learned that, knock on the door, you can repeat that, knock on the door with your drill. So you pass the first cortex, once you know where it is, you drill, you pass the first cortex, which is easy because you don't have any more cortex almost. So you use the hole, you mark to be sure that you don't slide, put your drill easily, and then you fill the second cortex, knock on the door, and then just drill to open and to do the hole. Then we use, this is very important, a 4 millimeter half-threaded cancellous screw. I don't want to use cannulated screw because they are fragile. We have a lot of fracture of the screw that we don't see with this kind of screw. Use a washer for compression. People say, the washer, you can have a risk for the human head. No, because the washer is not in direct contact with the human head. So definitely, and you want a compression and don't overhang. When you finish that, when you do that, you see, you have to flush. In case you flush too much, or in case you see, for example, this one is perfectly aligned, but in case you have overhanging, don't let this graft too lateral. Remove. You need to palpate with your finger. I didn't put the video here. I should. You use your finger and you can feel if with the cartilage, you can feel if there is overhanging or not. Of course, if it's underhanging, if it's too medial, it's not good, but it's better to be too medial than too lateral if you have to choose. The best is to be 1 millimeter, a little bit more medial than the cartilage surface, not the bone surface. And then when you are sure, if it is the case, if you are too lateral, remove with the ronger or a saw, remove the piece of bone which is overhanging. It's absolutely crucial. Then you have to remove. If you have to do that, you will remove the insertion of the coracoacromial ligament. It's not a big deal because you can still attach the capsule on the conjoint tendon to reattach the capsule in the best way. I don't know if you have noticed when I open the capsule horizontally initially, I try to do a sort of flap. You go in continuity with your incision, horizontal incision, and then you do a sort of flap of the labrum and the inferior part of the capsule that you will be ready to reattach like this. So yes, just to tell you that you can use a button if you want to do a compression, as long as you do a compression. So if you want to suture the capsule, because there is some controversy about that, maybe some question will happen later on, don't suture the capsule in internal rotation. I think it can explain some poor result of some Latarjet. The guy is doing a very good Latarjet, and to make it strong, the surgeon sutured the capsule strongly in the 0 degree or internal rotation. You kill the effect of Latarjet because Latarjet doesn't need that, but you will have sure good stability, but you will have a restriction of external rotation, and then you will conclude that your Latarjet gives restriction of the external rotation, which is not true in the literature if you use this correct technique. So when you cannot, first of all, you can decide to not suture. I know that some people don't suture the capsule after Latarjet, number one. Number two, if you're not happy with the fibers of the coracoid ligament that you left on the coracoid process to suture your capsule, you can still suture the capsule on the proximal part of the coracoid conjoint. And if you are not happy with that, because if you attach that on the coracoid conjoint, the conjoint tendon, for sure you will not reattach properly your capsule. If you want, then you can use a small anchor. Usually suture anchor are good between the corner between the coracoid and at the anterior rim of the coracoid, like any Bankart. So it's a Bankart effect. And for example, A.G. Itoy prefer this technique. He put two anchors just lateral to the coracoid, but then you can prepare before, you can prepare after, which is less easy if you're not happy with your capsule. So there are different techniques as long as you don't over tight your capsule. This is a very important message. So this is how we do. When I'm doing that, the arm is in external rotation max, strong and significant external rotation, and slight abduction to avoid any over tension. And that's it. I think we can go for the question later on. So thanks for your attention, and of course thanks for Michel Latarjet, who is this French surgeon that published his series of 4 cases on the technique in the Lyon Chirurgical. It's in French, so for that reason, few people have access to this surgery which was described in 1954. Can you imagine? The majority of people here, including me, were not on this earth. So it's a very long, old procedure, but the concept is still the same. And thanks to Gilles Walsh, who actualized this technique and describe perfectly the way to do. And I'm ready for the question.
Thank you, Dr. Philippe. I mean, it's always mesmerizing to see you on there, to see you and wonderfully explained. And thank you for your valuable time. I think I'll start the question sessions and I'll pass it on to my colleague. And we just have a lot of burning questions. It's always good to ask you. The French are known for the master on this and here. Now, I know it's all tricks and tips. It still itches me to go back to that question to ask about what would be your ideal number or bone loss cutoff. I know this is a very, very, very deputed questions. There are different concepts, but still, according to you, on a clinical practice, do you happen to measure the bone loss? And if you happen to measure the bone loss, what is your cutoff? Irrespective of the activity of the patient and things, do you have a cutoff limit for Latarjet, or it is like any percent more than 10% and high demand individuals, you butts towards Latarjet and not Bankarts?
Yeah, it's a very good question. Why? Because, in the past, when we didn't have this kind of surgery like remplissage, free bone block, all this kind of thing, it was quite easy. It was either Bankart or Latarjet. And it was a sort of conviction. Even I know some surgeons, French surgeons, they do only Latarjet, which is abusive for me, but they do only Latarjet, whatever the age, whatever the bone. Okay. Now we have some data and some more knowledge thanks to the study and that for different colleagues. And I like to follow what is study, the critical bone loss and the subcritical bone loss of the glenoid. So the glenoid is clear that the critical bone loss was between 20-25, and the people were doing Latarjet only above 20-25. I've never done that. I always my threshold was lower. So it means I like what we call the subcritical bone loss. And it's interesting because the progression of the IDs. Before, we didn't talk about bone loss, before this, Burkhardt and everything. Then we talk about critical. So Bankart was fantastic. Then we discovered that Bankart was not so fantastic after a long follow-up. Then we decided, some people proposed the critical bone loss. Okay, so people say, okay, under the critical bone loss, 20% you can do Bankart, roughly, and above you do Latarjet. Then people realized it was not working so much. So now we talk about subcritical bone loss, which is 30%, 50%, 17%, depend. Okay. Maybe we'll talk about pure bone loss one day. I know that it's important because we have to learn, and this way it's reducing. It's interesting, by the way, because to answer to your question, for me, the subcritical bone loss is clearly when I start to do Latarjet, not critical bone loss. Because I've been convinced for that, and I'm happy that there are some data supporting that. Now, if it is less than, I would say 10%, because 13% is because it's average of the studies, but let's say 10%. So it means less than 10%, you see a little bit of thing, but it's not very significant. Then you have to play with the rest of the assessment. So Hill-Sachs, because you need to do the Hill-Sachs to assess the Hill-Sachs, and we can come back on that because I don't believe in the concept of off track and on track, which is very clever, but we can come back on that. Hill-Sachs. Then because sometimes you don't have Hill-Sachs, so the risk is almost nothing. When you have Hill-Sachs, by definition, you have already a risk of additional risk. When the patient is young, you have additional risk. When the patient is hyperlax, you have additional risk. And when the patient is involved in collision and contact sport, I'm just talking about the IZ score that you can use as you want. Again, the IZ score is progressing. Now we are more and more. So, it's funny because we are coming back on what some of our mentors told us before without any true evidence, only their experience, that more you have this kind of thing, more you have to do Latarjet. And this is why I show you this diagram with these 3 arrows showing that the concept, the patient himself and the status of the patient is very important. So to answer more precisely, because otherwise people say we talk about everything, subcritical bone loss, this is my threshold. And then I will play my cursor with the rest of the evaluation of the patient.
I think that's loud and clear. When it comes to subcritical, I don't think the whole globe has an answer. We are going for DAS, new procedures and things. All we understand, we don't have a good answer. And I think the take home from your maestro is that subcritical, play works, err more towards bony procedure. Thank you for the wonderful answer. I'll pass it on to Dr. Senthilvelan.
Thank you very much, Dr. Philippe. That was like excellent talk. I mean, and a lot of making things even more simpler. So yeah, I have one question. I know you introduced a lot of slight variations and in the way Latarjet is done, and especially you do one screw. So which is with a washer, which is kind of like even when we saw Gilles Walsh technique and conventionally is done, we talk about rotational stability. So we'd like to hear more because that point is where a lot of people talk about now whether because we know that the superior part of the graft actually undergoes osteolysis, and is that any particular reason why you moved to actually a screw, or and what is your thoughts on rotational instability or stability of the graft, Dr. Philippe? Thank you.
Yeah, thank you, Dr. Santis. It's really an accurate and it's a common question. Okay, so why do we put 2 screws actually? Because the Latarjet was really spread on the world by the action of Gilles Walsh, to be honest, and because everyone respects him and it's justified. And we say in France by joke, we say Gilles Walsh when he says something, because we respect him so much, because he's not, he's a very honest surgeon. He never. He's super honest. He never lie, and then when there is something that doesn't work, he's telling it that it doesn't work. Yeah. So we respect him a lot, but we say Gilles Walsh is always right when he says something, except sometimes, like anyone. And what does it mean? It means Gilles Walsh advised to use 2 screws. Because he said, if you look at his amazing video on the ViewMedi, he said that, and I visited the Gilles, he taught me about that, and my technique was influenced by Gilles, of course, like everyone. And he said it's just to block the rotation. Okay? It was the first and main justification. So is it really mandatory to have 2 screws to block the rotation? Number one. And what do we have on the other side as a side effect and disadvantage to use 2 screws? I will tell you, for me, first of all, when you use 2 screws, you have more risk of fracture of the coracoid. Definitely. With 1 screw, the risk is much less.
True.
Number 2, as you said, the osteolysis of the proximal part of the coracoid makes an effect that if you do a CT scan after 1 or 2 years, if there is a osteolysis of the proximal part of the coracoid, so it means your screw is allowed without only scar tissue around. So this screw at the end is somewhere useless. Number 3, if you look at when you do Latarjet, if you look at the surface of the Latarjet, it's like raw glass. It's narrow in the middle, and it's a bit like this. The majority of when you put your 2 screws on proximal and distal, you do a hole in the good bone, cancellous bone. If you put a screw in the middle, the bone is harder because you have the 2 cortex closer to the screw, and there is more stability, and you leave a bigger surface of cancellous. I know it's not a lot because you can tell me, okay, this guy is talking about the surface, but it's a millimeter. Okay, but it's a small bone. If you have a small surface of bone, better to leave the majority of the surface cancellous bone intact. And now I will tell you why, because first of all, I have years of experience with this 1 screw, and we just finished a study that I share with one of my colleagues in Belgium that you know very well. You will see the study when it will be published. So he's a very excellent surgeon. So I choose an excellent surgeon who is doing a technique like me, or me like him, or whatever, but we do the same kind of technique, the valve technique. The only difference is using 2 screws cannulated. I'm using 1 screw with a washer. So we compare 50-50 patient, and we follow them, CT scan to all of them, to see the aspect. There is absolutely no difference in terms of rotation and consolidation. Only one difference, he had 1 fracture of his coracoid, and I didn't have. So, and I'm not surprised because it happened even for a very good surgeon, and he's a very good surgeon. So, and I have data now because I have data. I didn't have comparison, but we did a study with one of our fellows. We did a great job, and he compared the two group, and there is definitely no difference. So for me, based on this study, which will be published not now, but it's ongoing, maybe hopefully before the end of the year, I'm not sure. But anyway, for me, I'm convinced because this is my conviction at the beginning, but conviction is nothing without proof. And now there is evidence for me with a study that you can use 1 screw. So my message is not to tell, it's not orthopedic dictature to say you have to use 1 screw. No, I'm using 1 screw because I want to have uniform theory in my case. And I must admit that sometimes you have so big coracoids that why not to put a 2nd screw? Okay. But the message is that don't focus on 2 screws. Don't try always to use 2 screws because the risk, if you have a small coracoid, particularly people working in some area where patients have a small skeleton, IGI, we know that some people have a smaller, ladies or this kind of thing. What is the point to use the same side of 2 screws for this patient, the same than a big guy from a slave with big shoulder and the coracoid, which is sometimes a double of the coracoid of the first patient. So it means my message tell you with this paper is to tell you, no worry, you can use 1 screw. So do what you want, use your technique, which is the most comfortable, but the day you feel that your 2 screw will be compromising the solidity and with the risk of fracture, don't worry, use only 1 screw with a small coracoid. It works perfectly, but it works if you use in a good way So use a washer and use the cancellous bone, because if you don't do that, I cannot tell you that it will work.
Thank you
Okay?
very much. Because in a lot of Indian population, especially, because we see that the coracoid dimensions is actually much, much smaller. So it
Yes.
reassures us that, if at all, as you mentioned, if once we use one screw, we will still be okay. Thank you. I'll let Dr. Karthik ask more questions. We have more questions. Yeah, thanks.
Thank you, Dr. Philip. I think that was the main point. With the short period of time I happened to spend with Gil Walsh again, he's an excellent teacher like you, and he always keeps telling me that two screws. And when we started our practice back in India, where Dr. Senthil told, we have shorter skeleton, shorter shoulders, and it was always in our mind that we struggle putting two screws, and
Mhm.
when it was like something feeded when you didn't have one, you mesmerize or you hypothesize that it might fail. And today you've made a strong message: two or one is not an issue. What is important is make the bone heal. That's the point, I believe. Thank you so much.
Yeah.
And one another question again, as back in UAE, you've been my senior colleague here, and we have also started thinking about using buttons, and I've started using them as well. And you are also a fan. To be precise, I know what, again, the end message should be: what you use is not important. Use the bone heal. But what is your experience? I believe you and Dr. Pascal has a large scale experience on using buttons. Do you think it's the future? Should we change to buttons, or do you think it's the same and it's your choice, or what is your take on that?
I don't know yet. I know that Pascal Boileau, and I discussed long time with him about that. He is very happy with the button. He proposed to use only one button, and he has a great theory with consolidation. He's doing arthroscopically, and he said that with the compression with the button, there is no reason to use two buttons, number one. And the second thing he said, because some people use two buttons, he has two justifications. He said, don't use any more screws because it can give a lot of complication. He shows uh, some picture of complication. Okay, like because you see a lot of revision, I can show the same kind of complications with buttons. So it's not, it's not probably. I don't know if the button is more high demanding than the screw to be used. This is a question. I use buttons sometimes. I start a small series about button to compare. So far, there is no issue. Some people like Laurent Lafosse, I think he's still using screw and not button, if I know. So I think we don't have the answer for the moment. What is my feeling is that with the screw, when you are orthopedic surgeon, but maybe we need more experience. You know what is a screw. You know what is the sensation of screwing, fixing, compression. In a bone. With a button, it's a bit less obvious in our hands, but maybe because we are not used to do it to it. So I cannot say one is better than the other one.
Right.
I can say that the big advantage, I would say one of the big advantage, because I disagree with Pascal when he say a lot of complication with the screw. I don't have this experience okay. Maybe when you use two screw, maybe when you use a cannulated screw, I don't know. Maybe when you use this big plate sometime, but my feeling is that the patient, when he sees the X-ray, when he see a screw, it's, oh, you put a screw in my bone. When you see a button, it's more accepted. I say,
Especially in our part of the world.
yes. So you have to explain to the patient, because when the patient see the screw, he said, but he thinks that this screw is flying in the shoulder. He doesn't realize that it's in the bone. So you have to explain. With the button, I don't know why there is more acceptance from some of the patient. But I don't have enough experience to see if one is better than the other. What I can say is that the screw problem are overestimated by some people, because if you do properly your technique, there is no so much complication with the screw if you do properly.
100%.
Yeah.
I totally agree with you on that, especially in Middle East. Middle East, with my limited experience, I think with the screws and buttons, the only valid reason is that the patient looks more comfortable when I talk about buttons for reasons
Absolutely.
which I don't understand.
Exactly. Totally right.
So,
Dr. Philip, you talked, I think you briefly touched upon, you know, not good labral tissue, not hyperlaxity, because then sometimes, you get these patients who are not hyperlax, but who have very poor labral tissue because of repeated dislocations over a long time, and it actually abrades the tissue. So there's not much labrum to repair. So, where in those situations, let's say an example of not an athlete, but not an overhead athlete, but who has not got much bone loss, let's say about 4%, but who's got like, about 6, 7 dislocations, but has very poor labral tissue. So that's kind of this one category, and dominant arm. Would you consider doing a Latarjet because of the poor labral tissue, or would you actually think again of a Bankart tear with augmentation? What's your take on that?
Yeah, it's a very good point. This is one additional indication for Latarjet, and it was already advocated by Gilles Walsh a few years ago, by the way. He was talking more about hyperplexity, but the problem of this poor labral and capsular status is that it's not so easy to evaluate preoperatively. So I would say that, for me, I would answer in another way, if you allow me. The Bankart, for me, the good indication for the Bankart is when you see a real Bankart or Perthes lesion. So it means you see something detached, where the labrum is clearly detached, the 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 liquid, if there is an arthro MRI, or even you see there is a separation between the bone and the Bankart, and there is no big capsular pouch, which means that you can imagine that if you repair the Bankart, you will restore the anatomy, including the capsule, because you can still do a capsular shift in the same time. The problem, sometimes you just arrive in the joint with your scope, and you see that your capsule is not very good quality, which is not frequent, to be honest, which is not frequent because, in my experience, I used to treat majority of athletes or young people. So young people, it's more a question of hyperlaxity than a question of quality of capsule. Quality of capsule, as you mentioned, is more long history and so on. So usually these people are more 30, 40 than 20. So the discussion is different. So, when I'm in a borderline indication like this, I tell the patient the truth, always tell the patient the truth. You tell him, okay, because some people, they are a bit afraid to have a bone, screw, and okay, in comparison to this Bankart. We know that, all of them, all of us. So in this case, I tell the patient the risk of recurrence and advantage and disadvantage. Sometimes people say, you must introduce in this the heel sacks. If there is a heel sacks, the fact that I will do a remplissage, for me, it's an additional value to do that with a Bankart, even if the capsule is not good quality. You see what I mean? So if the patient, because you told me that it's not an athlete, if he's not an athlete, if he has a capsule which is bad quality, you feel that it could be bad quality. If there is a reasonable heel sacks that you can treat with remplissage, then you put the information on the table, you explain the patient advantage, disadvantage. Okay, you have a screw with the bone, but better result. On the other side, it's more anatomic, and we can still do the Latarjet later on, because this is something that you can always tell the patient, of course. More the patient, like on my slide, more the patient is hyperlax, more he is young, and more he has contact sport activity, more I will jump to the Latarjet and advise the patient to do Latarjet. We have this kind of intermediate patient that you mentioned, and we always have this kind of thing, and this is always a nice always nice case to discuss indication because we don't have enough data to tell this is better to do that, this is better to do that, because we need to include in the discussion many things, including the information of the patient, because some patients, they will take the risk. They will say, okay, I don't care if it is 15% risk. I don't want to screw in my shoulder as a first option. So as long as you discuss and it's a consent information,
Yeah,
I'm okay with that.
sure. Thank you very much, Dr. Philip.
Thank you. Thank you for the time and the answers, Dr. Philippe. One burning question to be sorted on the capsular closure. I mean, again, having spent time with his pointers on always preserve the CA ligament stump and just take a couple of points there. We also see a lot of surgeons not looking at doing that and just finishing off because we have other factors of stabilization. In your practical experience, keeping the CA and trying to close the capsule and not closing the hapule, does it really have a fact in the functional outcome?
We don't know. We don't know. You're right. First of all, there is no, in my knowledge, there is no study comparing same technique of Latarjet with suture of the capsule and with no repair of the capsule. I don't think there is a study. It could be interesting to do that. Probably some people will do it.
Because as you rightly told, I've been with Edgy who takes a lot of anchors on the radial side and close it. But my always one question is, are we and we have always seen that nothing, they still do good.
You know, when I was educated, when I was resident to be Latarjet, because we learned Latarjet when we were residents at this time, we didn't reattach the capsule. Gilles Valch introduced this elegant way to reattach the capsule, and I was a bit convinced because I said, okay, why not? Because you know, you do something which is a plastic, but it's a plus, Bankart plus, so why not to do a Bankart in the same time to avoid the capsule? Okay, we don't have data to support that. It's like the rotation. Huh? Gilles Valch is a scientific man, but when he say do that because you block the rotation, he doesn't have evidence for that. He has experience, but there is no evidence. And for this capsular reattachment, there is no evidence in my knowledge for that. We need that. What I know is that it's not you can do it. So there is no evidence that it's better or not. But in my experience, and I think it's clear that, okay, there is no evidence as well because we don't have a comparative study. But we see a lot of restriction of external rotation with over-tightening because people want to do it. So the message is to say, do what you want, but if you do it properly, because otherwise you will waste the result of your beautiful Latarjet.
It makes sense. And that's why the complication has been overfilled as 30%.
Yes.
In real sense, the Latarjet should be less than 1% if done properly, I think.
Agreed. Correct.
Thank you.
Yeah, thank you very much. There are obviously, you know, the obvious worry with the Latarjet is especially for beginners, Dr. Philippe, is having a disaster like a musculoskeletal nerve injury, or in fact worse, axillary nerve injury. And the advantage quoted for an arthroscopic Bankart repair, you know, even though the results we know that over if you compare them after 4 years or 5 years, even in equivalent group, you know, the redislocation rates are higher. But the advantage quoted is this nerve injuries or complication rates in some studies, which is more often removal of screws or screw irritation, you know, if you critically analyze it. But the point I was trying to ask is that when you have you had any musculoskeletal nerve injuries or even traction palsies in your experience, and how do you deal with them? Obviously, you pointed out in your technique how to avoid it. Don't give too much traction or don't go below 2 centimeters below it. But at all, if you had it, or have you dealt with any musculoskeletal nerve injuries of other people after having Latarjet, and how to deal with them?
So I should not tell that because it's quite weird, but I have done 100, maybe 1,000 of this kind of surgery. I've never had a nerve complication
That's amazing.
But yeah, I mean, but let me finish the sentence because unfortunately, but I think it can happen and you don't detect them because I don't have history of musculocutaneous palsy or deficiency after my Latarjet. Clearly, I've never seen that because you ask the patient, you follow the patient for the recovery and so on. But some study have shown, some electromyographic study have shown that there is some slight effect which are probably diluted in the recovery process by the weakness, global weakness of muscle. So it means, sometimes I say the risk for the musculocutaneous nerve probably is not so high because if you see some unexperimented surgeon doing that, we have never seen a complete palsy of the musculocutaneous nerve after Latarjet operated somewhere else. So it means probably the musculocutaneous nerve is not so fragile or you see what I mean? I mean, prone to have this kind of lesion. But we should not tell that because I think we probably missed that. And there are some study, one done by Gilles Weitz, by the way. They did EMG and they showed some transitory deficiency, like he did a study about the scapula imbalance after this kind of thing and with progressive correction, but we don't detect them clinically because it's not like an axillary nerve. When there is a palsy of the axillary nerve, even a partial, you can clinically suspect immediately. Musculocutaneous nerve with the motor deficiency, I've never seen that. Maybe the patient had, some of my patients, maybe they had some very low grade deficiency that recover, at least they recover. So it was not cut or this kind of thing, because to cut the musculocutaneous nerve, I think you need really to not be careful. So the risk is more a traction, or a small damage on the nerve, but not interruption of the nerve itself. So I believe that we must still act in a way to advise prudence to the surgeon and to not tell too much. We don't have so much musculocutaneous nerve palsy because maybe it can explain some patients who are less recovering in terms of speed of recovery after this kind of surgery.
Thank you very much, Dr. Philippe. That's heartening to hear that, when you follow the steps correctly, then your complications are really, really low. That's probably the point here. Thank you.
Thank you. Thank you for your valuable time. Is it okay? One last question. Do we have time?
Yeah, of course.
One last. Very basic question. What is your rehab protocol? How do you work on them? There are different protocols. What is the basic of your rehab post Latarjet?
Very simple, and I did a short text, phase by phase, week by weeks, for my patient, and I give that to the patient and the physiotherapist. Actually, it's not very complicated because the big advantage in comparison with Bankart, for me, this is something that we learned with Gilles Weitz, because he said clearly, when you fix your coracoid bone graft strongly, when you suture or repair the capsule in external rotation, there is absolutely no justification to restrict the abduction and external rotation. So it means I always tell my patient, don't do whatever you want as long as you come progressively. The only thing is to go to not the message to the physiotherapist is to not stress the coracoid with the exercise with the conjoint tendon during 6 weeks, but you can do a lot of work without any restriction. So to summarize, and this is the beauty of this surgery, you don't have specific restriction. You progress the physiotherapy as it comes. And the main objective for me, the first thing is to say during the first 4-6 weeks, your main objective is to not be stiff, to not lose your external rotation. Because if you lose your external rotation, then you struggle to go back to play. And when you do that, I have a lot of high-level athletes who are going back at 4 months, which is, you say 6 months, but some of them are going at 4 months. But I always do a CT scan, control CT scan at 3 months. So I do a CT scan because X-ray, you don't know if it is consolidated. You do CT scan at 3 months. And then this is how we did this study, comparing the thing, because I did systematically, I said, okay, why not to compare with someone else? So my colleague implement this protocol as well. And so we do CT scan at 3 months, and we have all this data at 3 months. And if there is a perfect consolidation of the bone, that there are some criteria that you can discuss, but with the CT scan, you can see if it is correctly consolidated. Then at 3 months, after the patient has done the CT scan, I send a message to the patient and I tell the patient and I send the patient a message to the physiotherapist. Now, no restriction as it comes. So you can go back to play. But of course, now the question is, don't go. It's like for the ACL. If your ligament is good, your coracoid process is consolidated, is good. If your motion is good, it's good. But if your muscle are not good, whatever the status of your shoulder, you have to wait until the different testing of muscle strengths are good to go back to the field. Simple as that.
Thank you.
Thank you very much. I think that's been an excellent session, Dr. Philippe, but we are already going past our time. That means that it's been really, really, interesting to actually discuss with you. But maybe we'll just finish off with one question, if Dr. Karthik may allow, if it's okay. So, I think we
Philip should allow.
yeah.
Okay.
So,
Sure.
we actually had this. I know you briefly touched upon the track. It's a big topic by itself, but but what I wanted to know is, we talked about the lower limit. You talked about the subcritical. You might actually do it in an athlete, even if it is a subcritical bone loss. What is your upper limit? I mean, this is like, is it like a 25-30%, or would you still do a remplissage with Latarjet? Because it always is a mixed concept. People tend to actually combine things because the Latarjet makes it non-engaging anyway. So, maybe we'll close with this question with your thoughts on what is your upper limit, and would you ever do a remplissage with a Latarjet at all?
Yeah, so this is interesting because these limits are the opposite side. So it means, if I understand the question, when the bone loss is huge, so it means there is a big part of the glenoid which is missing, with the inverted pair deformation, which is huge. You have to measure on the CT scan, because the coracoid process, depending on the patient, if you look at, you can refer to some study calculating the average thickness of the coracoid. You cannot restore always the thickness, the dimension of the glenoid only with the coracoid process. This is why Joe De Beer proposed this clever technique with the congruent arc restoration, because then you can use the standing position, I would say, instead of lying. Unfortunately, the coracoid is so thin that you have high risk of fracture and risk of non-consolidation, because the surface of the bone, which is against the glenoid surface, is very small. So the risks are clearly higher, and I don't recommend, in my experience, I don't think it's a good idea to do this kind of thing. So you need to change. If you cannot, the coracoid process usually is maximum 10 millimeter. You can maximum, or maybe more if you have big guys, but particularly because you remove a piece of cortex. If you have this kind of bone loss on your glenoid above this, so it's not only a percentage, then it's a question of size. So you have to measure in millimeter the real bone deficiency. And then I think you should go for Edeni Binet, whatever the choice, iliac crest or allograft, definitely. If you want to restore, we are more in, this is the limit between, it's the same topic, but it's a simple anterior shoulder instability with bone loss, until then it's I would say joint fracture, joint deficiency. It's like a tibial plateau which is missing. Of course, your joint will be unstable, but it's due to the bone deficiency. So you have to restore the anatomy. And for the heel sacks, I think if your heel sacks, or this is a discussion, I cannot tell you which percentage because it's so even it depends on the depth and the width of the lesion. But if it is very important, I go for an allograft. I see a patient that I will operate soon. It's a failure of Latarjet done by one of my colleagues in Saudi Arabia. Perfectly done. I know because he using the same technique. He's a very good surgeon and he did that perfectly. But the patient had epilepsy seizure and now he's okay. But he didn't know that he had epilepsy at this time, so he ruptured his coracoid. So now and the heel sacs is absolutely huge. So in this case, you have to do to treat the anatomy, and the remplissage is not enough. This is to talk about the remplissage. So remplissage with Latarjet, yes, if I believe that Latarjet is good enough for the glenoid, but the heel sacs is too much to do a remplissage. Number two, Latarjet is not enough to correct the glenoid deficiency, then move to the bone graft, hidden in my opinion.
Thank you very much. Thank you very much for your insights. Thank you.
Thank you so much. I think
it was a pleasure with so brilliant moderators like
no.
both of you.
You feel us the other way. It's the fanboy moment.
No, it's
first of all, with your busy schedule, it's not like it. I personally know you, and it's hard balancing both. And you have been path guiding for especially people like me who are sitting in the Middle East and throughout the globe, how to balance academics, work, and everything. So and we've been pulling. We have just booked you for 45 minutes, and we've been so gracious enough to sit back, answer all our questions. I believe this would make a change for the youngsters, especially the concept is to happen very slow, very precise. There's not much of confusion because when you learn a technique and you have so much of information around you, which is good, which is wrong, is the most confusion that you start with. And you made all the questions very easy and precise. Thank you for time. I have no words, and I believe we're gonna make you meet soon and very soon back in the southern shores of India, which you're already doing it. But once again, so
pleasure. It's always a pleasure. Always.
Thank you. And I would also take this opportunity to thank Dr. Senthil, who's heading the Department of Shoulder and MIOT, a good senior colleague. And whenever I ask him, he never says a no. Thank you so much.
Thank you. Thank you. Bye.
Thank you, gentlemen.
And also OrthoTV in supporting us. Thank you, all these things. We will meet again.